In this video, we look at the conduction system of the heart. It's part of Unit 2, Key Area 6. We're going to explore the timing of cardiac cells and be able to explain things like the cardiac conduction system, what regulates this system, what keeps it in the right order, the role of the medulla in regulating the heart rate, the autonomic, sympathetic and parasympathetic systems, and how everything works antagonistically. We'll also be able to look at an ECG and describe what it shows. So the conduction system of the heart. The heart beats autogenously. It beats on its own without any external stimuli. It's regulated by the nervous system and by hormones. If you take an initial heart cell, any one of them, and put it in a petri dish, it will beat, but it will beat at its own rhythm, completely at a different time to every other heart cell. You need something to make all of them go at the same time. And what we do here is we use a little node at the top of this right atrium and one down here in between the atrium and the ventricle to control that. At the top we have what's called the sinoatrial node. It's also known as the pacemaker. Number 2 here, we have the atrioventricular node, and then we have some other words that are not really part of the course, like bundles of His and Purkinje fibers and other very interesting sounding things. So the sinoatrial node is found up here at the upper portion of the right atrium. It's known as the pacemaker. If somebody's SAN node is not firing properly, either due to disease or damage, then you can have an external pacemaker added to the body, and this will do the job of the sinoatrial node. The cells of the heart are autorhythmic, so they have their own little rhythm, and you need something to tell all the cells of the heart to beat at the same time. So the sinoatrial node ensures that both atria will contract simultaneously, and it then sends a wave of excitation down to the middle of the heart and round to the atrioventricular node to tell the ventricles to also contract at the same time. As we know before, when the atria contract together, it's known as atrial systole. So the AV node. The sinoatrial node has passed its electrical signal down, its waves of excitation, and this is received by the AVN or AV node. The impulses from the AV node will then travel down the fibers of the heart and the central wall, and then when they arc across the heart muscle in the ventricles, they will cause ventricular systole, so this contraction, pushing of the blood up through the semilunar valves and against the atrioventricular valves, closing them. So the autonomic nervous system will regulate the rate of your heart rate. It will regulate the emptying and control of your stomach and the absorption of nutrients in your intestines. It also controls things like your vasodilation and your vasoconstriction. So these are all completely involuntary, and it means that you don't need to control these consciously. They're done by the brain without your permission, essentially. The medulla regulates the rate of the sinoatrial node through the antagonistic actions of the parasympathetic and sympathetic systems. So the sympathetic pathway and the parasympathetic pathway. Both are constantly firing electrical signals down, and we'll look at how that works. So the sympathetic accelerator nerves coming off the brain will tell the heart synapses to release the neurotransmitter noradrenaline. Noradrenaline will increase the heart rate. So in the absence of the parasympathetic, the sympathetic, it's very difficult to pronounce this, sympathetic system will be telling your heart to speed up. The parasympathetic at the same time is using its nerve fibers to cause the synapses to release acetylcholine, which is this neurotransmitter here, and it tells the heart rate to slow down. If more nerve impulses are being received by the heart and telling it to produce noradrenaline, then there are parasympathetic nerve impulses to release acetylcholine, then the heart will go faster. If there's more parasympathetic acetylcholine than there is sympathetic noradrenaline, then the heart rate will decrease. So both are firing at the same time. It's which one has the stronger signal at any one time. Some activities will use the sympathetic nervous system and will cause the adrenal gland to produce adrenaline. This acts on the sinoatrial node and increases the generation of your noradrenaline. So adrenaline will cause more adrenaline to be produced. So that will increase your heart rate when you get adrenal function. So we can actually look at the impulses and the currents generated in the heart using something called an electrocardiogram, or ECG. The signals that make the heart fibers contract come from the sinoatrial node, and we can look at the electrical impulse via this way. So this is what an ECG will look like. You'll have what's called the P, and then the QRS complex here, and then the T. Each of these ups and downs, the charges and the depolarizations mean a different part of the cardiac cycle. So you've got the P wave, which is the electrical excitation from the SA node spreading across the atrial muscle tissue. So you can see this up is the spreading of the electrical signal. We then got what's called the QRS complex, or QRS wave. So it's a wave of excitation giving you ventricular systole, and then the recovery of the ventricles gives you this T wave. So this is lots of funky diagrams showing you the P wave, the QRS complex, and the T wave. This is repolarization, and how it maps out onto the ECG. You don't need to really understand this anymore, but being able to tell the difference between a normal heart rate, counting the squares. So for example, here between peaks we have 1, 2, 3.5 boxes, and here we only have 1, 2 boxes. So this, if this bit of graph paper here showed 1 minute, for example, a very low heart rate, but anyway, 1 minute, you'd be able to get 1, 2, 3, 4, 5, 6 peaks, and in this one you'd be able to get 3, 6, 7, 8, 9. What's this individual's heart rate? So just to make it even more difficult, they flip the image upside down. So if you look at the distance between the P waves, or you can do it with any part of the complex, and we've done this previously with PCR diagrams. You look at how many boxes are there between any two identical points. So if we look at this between R and R, we have 1, 2, 3, 4, 5 big boxes. It says here a big box is 0.2 seconds, so there's a full second between each beat. If your heart beats once per second for 60 seconds, your heart rate will be 60, because it's the number of times your heart will beat in a minute. This is an abnormal ECG. It's called atrial flutter, or fibrillation. Rapid contractions of the atria. It contracts 3 times for any ventricular. So you can see lots of atrial flutter, then a ventricular systole. Atrial flutter, ventricular systole. That's not a great one. This one is worse. It's called VT, or ventricular tachycardia. It means a fast heart rate or ventricular beat. So the ventricles are beating rapidly and independently, but at least they have this nice regular look. This is VFs, or ventricular fibrillation. So we talked about the fact that heart muscle cells are able to beat in their own rhythm if you don't control them. This is what's happening here. The muscles of the ventricles in the heart are beating whenever they want to, and it's giving a very ineffective ECG. So in VT, ventricular fibrillation, or VF or VT, you can shock these using a defibrillator. So what a defibrillator does is it sends a big shock across the heart muscle and says, right, stop that now, let's just get this all sorted. And hopefully the heart muscle then goes, all right, so I was being a bit silly, let's listen to the sinoatrial node again. It can take a few shocks, and it can send you into even worse rhythms. And you can get some other heart rates as well. So when you've got an abnormal ECG, if you think about it, you're not getting atrial systole, ventricular systole, diastole, atrial systole, ventricular systole, diastole. So you can't properly fill each chamber individually, and you can't properly empty it in a coordinated fashion. So that's not a good one. So have we looked through your booklet and have a go at the questions? Think about these ones here as well. So do you know the name for the heart's pacemaker? What makes the atria contract? What makes the ventricular systole happen? What part of the brain regulates heart rate? Something regulates the rate of the sinoatrial node through the antistic action of what? Something accelerating nerves, release something, and slowing something, nerves release something. So We know that the medulla regulates the rate of the sinoatrial node through antagonistic action of the autonomic nervous system. We know that our sympathetic axillary nerves release noradrenaline, and slowing parasympathetic nerves release acetylcholine. We're just going to quickly look at blood pressure while we're here. So you should know what causes the different parts of blood pressure and roughly how to measure it. So the blood pressure is the force exerted on the walls of the blood vessels. Normally, if you take someone's blood pressure, you will find it's 120/80. So the 120 is the systolic blood pressure and the 80 is the diastolic. We'll talk about what those mean. So measuring using a machine called a sphygmomanometer, it's a very fancy word. You can use digital or manual sphygmomometers to do sphygmomanometry, and you measure it in the unit of millimeters of mercury. So both the systolic and diastolic blood pressures can be measured by using this sphygmomanometer on the upper arm. What we do is we have the moment before the cuff is on, your natural blood pressure through the arteries, there's enough force constantly, enough pressure pushing on the walls to just have the blood keep going down the arteries even when the heart is not beating in ventricular systole. So even in ventricular diastole, the blood is moving. If you were to increase the blood pressure using this cuff pumping it up, eventually you get to the point where just the natural diastolic blood pressure when the heart is relaxed is not enough to push past that cuff. That is the pressure that we get for the diastolic. So in this previous one, at a pressure of 79, the blood is able to get past. At 80, the blood can no longer get past, just when it's relaxed. However, at a blood pressure of 80, when this cuff is exerting 80 millimoles of mercury pressure, the systole from the ventricles, so the contraction of the ventricles, can still get past. You have a little monitor on the side, so you use a stethoscope to listen. The point where you cut off the diastolic, you start to hear a wee sound. So you pump it up until you start hearing a sound. That gives you the diastolic blood pressure. And then you keep pumping until even the ventricular systolic blood pressure cannot go past. So that's how you get your systolic blood pressure reading. It's the pressure at which, even when the ventricles systole, contract, they can't get past the cuff. So there's different pressures. So in the arteries, particularly the aorta, which is the one that leaves the heart at the highest pressure. So ventricular systolic pressure will be highest at the aorta when we're going through ventricular systole, and lowest in the aorta when the ventricles are relaxed. So in ventricular diastole, still a decent pressure. As you move further away from the heart, you get into the arteries, which more or less have the same pressure because it's pretty close. And as you get further away from the heart, the systolic and diastolic blood pressures will kind of start to meet. Because the diastolic blood pressure is really just the normal intrinsic pressure that the ventricles are exerting, it doesn't really tend to change much in the arteries. And then when we get into the capillary bed, you get this big drop in blood pressure. So there's certain things that can cause high blood pressure: poor diet, genetic disorders, hormones, pregnancy, recreational drugs, things like that. You are asked in your booklet to talk about a diagram. So on page 34 of your booklet, this is the diagram it wants you to look at. So you should know the following. What's the blood pressure? It's the pressure that the blood exerts on the walls of the blood vessels. The unit for measuring blood pressure is millimeters of mercury. Hypertension is high blood pressure, so above 120/80 roughly. And some common causes are things like poor diet, lack of exercise, and genetic issues. So that's everything you need to know from this key area. Just have a look over some of the videos if you're stuck on anything.